Hello, everyone.
Everybody,
Welcome, welcome.
can we get a thumbs up for everybody if they're ready to begin? A head nod, something. Cool. All right. Well, welcome to our review session for midterm 2. Give me 1 second. Again, I'm Jose, your BioSci peer tutor.
And I'm Monica, your other BioSci peer tutor.
And I'm Ariella, your other BioSci peer tutor.
These are our office hours, links, and emails. Feel free to reach out to us with any questions at any time before your exam. We'd be happy to help, okay? And please take the time to fill this evaluation out as soon as you get a chance after the midterm review. So it helps us help you guys, okay? These are the topics we're going to cover today. I'll be going over cardiovascular, and then my fellow co-tutors are going to be covering respiratory system, control, and exercise physiology. Okay. So this is mine. I'm going to be presenting the cardiovascular system for you. And throughout my lecture, I'm going to have little breaks. If you have any specific questions, feel free to hold them off throughout the break. So after every lecture, I'm going to have like a short break. And then if you can hold your questions up until then, so that way we're not constantly stopping and going. We have a lot to cover today, so we'd like to get through all of it for you. And if anything feels like it wasn't covered enough, just feel free to reach out or stay to the end and we can go over it together, okay? So the functions of the cardiovascular system, essentially you just have to know what it does, what it helped with, what it contributes to. So then that way you're aware of how the cardiovascular system operates in general human physiology, how it transports things like O2 and CO2, the nutrients, the cells, and how everything just around the body. That's the main function of the cardiovascular system, is to keep things going, right? So it keeps our bodies functioning properly. So here's your heart. And make sure you know all the major structures. Try to know their order of, like, if they started with, if blood was formed from the right atrium, where would it flow to next? Try to know their general locations. It helps if you can look at one of these diagrams and just make everything blank and fill it in yourself from memory. That'll help you in this course. It'll help you in future courses. So just make sure you can do that, because that's going to be helpful throughout the coursework. Try to play with the order a little bit, see if you can quiz yourself on what goes next, and know where like oxygenated blood is going to be and where deoxygenated blood is going to be, because those are going to be key factors in your questions. This is a little trick I put in there to try to remember tricuspid versus mitral. Just know that it's right to try. That'll help you remember that the tricuspid valve is between the right atrium and the right ventricle. And then by default, you'll remember that the mitral valve is in the left side. Here's the various valves of the heart. Know which ones are which, because in the question it might not be clear. They might not specifically say the mitral valve. They might say an atrioventricular valve, or they might say a semilunar valve, and when they're referring to the aortic or pulmonary valves. Know the differences between those and the different names. Like bicuspid valve has more than one name. You can also refer to it as the mitral valve. And then this is another view of those valves. And their whole purpose of these valves is to prevent backflow of blood. So when pressure pushes the blood in one direction, you want to prevent the flow of blood from coming backwards. So if you left the ventricle, you don't want to go back into the ventricle. Know which valve is associated with leaving from which part of the heart. If you left from the right ventricle, know which valve is going to prevent the backflow of blood from the right ventricle. Back into the right ventricle. So the way our heart works is like a pump. Think of it as like two pumps, and each side is one's gonna pump to the lungs, one's gonna pump to the body, and it's just gonna continuously keep this circulation going, and that's what's keeping us alive. So know which side of the heart is gonna pump the deoxygenated blood and which side is gonna get the oxygenated blood, and how the blood flow makes its way throughout the body and to which part of the heart it makes it to. Just keep practicing that order until it becomes second nature. It's gonna be helpful. So here I've included a little, a little cartoon for you guys. It'll show the blood flow. You can we'll post all of these slides, by the way, so then you can refer to them before your exam. And it just has the general pathway of the blood flow. So if you can practice this a few times until you get it by memory, it'll make it easier. Okay, know the difference between arteries and veins. I'm sorry if I'm going a little fast, by the way. I'm going to speed through it just because we have a lot to cover. And towards the end, if you have any specific questions or things you want me to touch back on, or any one of us to touch back on, we'd be happy to do so. But I want to make sure we cover through all of these slides, okay? So I'm giving you a general overview, and I'll have some practice questions for you at the end of my lecture. Here we've got the arteries and veins. Pretty much everything you see here is something you should know. You got a little cheat sheet on the right there that'll help you distinguish between the two, and that'll help make it easier for you to know which one we're referring to or what they do. And specifically know that arteries carry blood away from the heart. I like to remember that with the A in artery and away with A and away as well. Okay. And then veins are the opposite. So one trick that they might implement would be like pulmonary arteries. You would think that a pulmonary artery is going to be oxygenated just because you're already used to knowing that an artery in the heart usually carries oxygenated blood. A lot of people make that association, but don't fall for that, because pulmonary artery is actually taking blood away from the heart, and that blood is deoxygenated. So know that artery does not mean oxygenated or deoxygenated. It means that the blood is moving away from the heart. This is something that one of my co-tutors is going to cover a little later, but I just thought I'd include it in there so you guys can get a general feel for what's going on. And this is basically capillary change and how the blood flows through the arteries, arterioles, and eventually makes its way to capillaries where the exchange occurs, and then it sheets onto the venules and the veins. So a big one here, and you're probably going to see several questions on this, is going to be the cardiac cycle. Know the cardiac cycle. Know where ventricular diastole is happening or where systole is happening, and try to associate each one of the waves on the ECG with each one of the phases in the cycle, so that you know what's happening in each phase. You know how the ECG is responding to that, what it's picking up. So start with isovolumic or isovolumetric, it's the same thing, relaxation, and this is ventricular diastole. When diastole is being mentioned, it's referring to rest. So at this point, the heart is resting, and therefore blood can fill. Okay, so know that when the heart is resting, blood is filling into the heart. When the heart gets filled up, would be then it can go ahead and push that blood outward. And to push the blood outward, you would want to go through atrial contraction, right? So atrial contraction is going to start at the top, and that's going to contract and push blood from the top down to the ventricles. And then when the ventricles are full, then they're going to go through the process of pushing blood from the ventricles out the body and the lungs. Okay, and just know that you can't start at the ventricles, you have to start at the atria. So the atria come first, then the ventricles go up, and then the ventricles push out blood to the lungs and the rest of the body. This is a good cheat sheet kind of thing, a study guide. If you understand everything that's happening in this graph, and you've got the different valves, the phases, and you've even got the heart sounds there for you. If you can understand this graph or any graph that you see that's similar to it, where it's got the pressure of each one of the, what do you call it? Like the aorta, the ventricles, the atrium. If you've got a graph like this and you understand what's happening in each one of these scenarios, then you can answer any one of the questions that they're going to answer with. But this is just like a nice way of looking at it, of representation. And you can kind of see where the blood flow is happening and what's happening in the heart. Again, this is kind of like a build up of the last one. It's got the same thing going for you, but it's going to be more helpful in the ECG component, so you can trace what's happening in the ECG. So you would know that when arterial systole begins is when the P wave is occurring, and that just means atrial depolarization is happening. That blood is going to be pushed from the atria down to the ventricles, and then you see how you've got the ventricular systole. So then that's when the ventricles are going to be pushing blood. But at this point, once the blood has gone through the atria to the ventricles, those valves that are between the two are going to be closed. Between those two chambers, you got valves and they're closed. So then that way the blood cannot flow backwards. Whole purpose of valves in the cardiovascular system, you're going to see the same thing. It's preventing backflow of blood. So once they're open, blood pushes forward. Once they're closed, blood cannot push backwards. So QRS complex is the biggest one, and you're going to associate that with the ventricles depolarizing. Know that the biggest spike you see in an ECG is the ventricles depolarizing. You can associate that with the ventricles being the biggest muscular part of the heart. They're the ones doing the most work. So you would see the most electrical activity in an ECG. All right. And then you can follow through with the rest of the phases. And again, if you have questions towards the end, we can go over it together. So this schematic, it's just a cheat sheet. I've included it in here for you. It gives you where the pressure is higher, atrial versus ventricles at each stage. It also gives you which valves are closed, what sound is being made, and what's happening in the EKG. This you can refer back to in your own time. I've even included a link to the video. It's from basically my favorite physio guy. He covers a lot of in-depth stuff on YouTube. So I would suggest if you're having any difficulty with like a specific part of physio, type in Ninja Nerd and type in whatever you're interested in, and he'll go in detail. I've included a link on the bottom, and again, you'll get the slides so you can go ahead and view this. But each one of these, it's going to go through each one of the phases of the cardiac cycle and give you a rundown of what's greater pressure, which valves are closed, sound, and EKG. It's a great way to look at this right before the exam because it'll help you. It'll save you time. I included a little meme for you guys. Resting, exercising, and of course, finding out that the midterm is going to be covering at least half on cardio, and being unprepared, you're going to feel a little wacky, right? So does anybody have any questions before we proceed on what I've covered so far? Unmute yourselves or co-tutor, let me know if there's anything. If not, I'm going to proceed. So this section is going to cover the cardiac muscle. And I forgot to mention on the top right corner, I've included here which professor covered this part of the material. So it helps you be more prepared so you can look through your lecture notes and be able to find who did what. So this, yes.
Sorry to stop you. Very quick question about ventricle systole. There's two steps. One of them is the valves close, so that when it contracts, the blood doesn't go backflow. And then we have the semilunar opening. What's the time difference between those? Is it like there's some time?
Right, it's a short amount of time, but it's all of this is happening in the milliseconds. So you wouldn't be asked, was it 20 milliseconds or 50 milliseconds? You wouldn't be asked at a specific time, but it's just enough time for the blood to fill up the ventricles and then that pressure to build up. And then eventually
pressure build up.
Right, yeah. So the pressure just builds up and then eventually overcomes from the ventricles exiting through the semilunar valves out into the aorta.
Does the R peak associate with just right before the semilunar opens up and just right as the pressure is kind of the highest?
Good question.
Or we don't really need to know the.
We don't need to know that. You would need to know QRS, just the whole peak. It's not which like what the Q is doing, what the R is doing, what the S is doing. They're not going to split that up for you. Know that that whole peak is referring to that component of it.
Great, thank you.
Yeah, no worries. All right, so cardiac muscle. Just know the big one here is know the difference between cardiac muscle and smooth and skeletal muscle. So they might throw in something where they're trying to see if like you might get them confused. You might get something from skeletal muscle confused with cardiac muscle. There is a lot of similarity. So just try to highlight the differences, and I might go over, I'm going to go over a little bit of that in my later slides. So know that the cardiac muscle is involved in conduction. So it's got specialized cells that perform this conduction. You've got the contractile cells that go ahead and create the pressure that generates enough pressure to push that blood from the heart to the rest of the body. Okay, the heart functions autonomically, or like I like to think about it, automatically. And you're not thinking, hey, I want my heart to beat at 100 beats per minute. It happens, right? You can't control it sometimes. So there are stimuli that go ahead and influence how your heart beats, and some things will make it faster or slower. We're going to go over those things in a minute. And of course, don't forget the pacemaker function of the heart cells. So your heart has its own built-in natural pacemaker that's maintaining your heartbeat at a specific rhythm. You're trying to stay alive, so this autorhythmic cells are going to keep your heart beating constantly for the rest of your life. If anything goes ahead and fluctuates that, whether sympathetic or parasympathetic innervation, it's going to either speed up or slow down your heartbeat, and that's going to affect the rest of how your heart functions. So I'm going to go over which components of the nervous system are going to speed up or slow down your heart and how that functions. But just know there's the pacemaker automatically maintaining your heart rhythm, and then know that there's cells involved in the conduction and the contraction of your heart. So this is a general overview of the structure and how it looks. Try to know which one of these parts how they each perform a different component of cardiac muscle contraction. So here we've got a general action potential for cardiac cells. And remember that this is different from skeletal muscle and smooth muscle. Know what's happening in each one of these phases. So know that in the beginning, you've got sodium coming in and causing that peak. Then you've got the depolarization happening. When potassium channels open, then potassium is generally more concentrated inside. So if the potassium channel opens, it's going to leave the cell. Then we've got calcium coming in, and when calcium enters the cell, that causes depolarization. And then again, so basically just know how the whole cycle goes through and just follow the different stages. Again, here's another representation of it. And the big one here for the difference between skeletal and cardiac is that refractory period. As you can see, it's a lot longer. And if you had no refractory period, then you would not have enough time in between beats for the contraction. If you have a very short refractory period, then your heart would either constantly be beating without giving it enough time break for each, or basically the contractions to go from atria down to the ventricles. You need that time for the depolarization event to travel down the cardiac muscle cells and eventually have that rhythm that pushes the blood out of the heart into the body. So this is a good comparison, and it shows the differences in skeletal muscle versus cardiac muscle. You can read these notes on your own time, and that way you can get a better understanding, or you can ask questions after the lecture is over. So this is a big one. Know each one of these steps, go through it step by step. They might just throw in something that tests understand one of these steps, or they might throw in a wrench and try to say, hey, is this component of the cardiac muscle contraction similar, or how is this one different than skeletal muscle? Because they look very identical. So the big one is that calcium that comes into the cell during that plateau phase makes it a longer phase, and that's due to the cross-bridge cycling. So know that difference and know any subtle differences that you might pick up. Look at the two in comparison, highlight what looks different, and be able to answer a question that tells you, okay, hey, look, here's a component of the skeletal muscle contraction. And they might just throw in a true or false, or try to put in a question that gauges to see if you understand the differences between the two. Do we have any questions up until this point? All right, so this is the electrical conduction in the heart. I like to put these things on the left so you can kind of refer to where in the lecture notes we're talking about what. So it just kind of helps you be organized. This one is going to be the autorhythmic cells. They did mention the funny channels, which you would have to understand why they're different than regular sodium channels and how this whole action potential takes place and what it does to the heart. So when the funny channels open and the sodium enters, this is similar to the regular action potential that we're used to, like in the neural conduction. You do recall that sodium comes into the cell, depolarizes the cell, and then the rest of the cascade falls through. But in this case, instead of just the sodium being the key factor, it's actually calcium. And when the calcium comes in, the calcium is going to depolarize the cell. So calcium is a key player in cardiac muscle contraction. So when we have the calcium coming in, eventually it reaches the very top. Here we see step 4, and that's when those channels for calcium are going to close. And the inverse is going to happen. Basically, instead of depolarization, we're going to get down to repolarization, and that's due to the calcium channels opening. is open, potassium. When potassium channels are open, potassium can leave the cell. When potassium leaves the cell, it takes the positive charge with it. And when it does that, it brings it back down to a negative state. Okay. Here we've got the electrical conduction of the heart. I highlighted the nodes for you. Just know each one of these nodes. Know there's the SA node, AV node, and don't forget about the Purkinje fibers. Know which one controls what level of heartbeat or rhythm, and know the order of them. So essentially start off at the SA node. That leads to the depolarization event. And this activity travels through this internodal pathways and goes ahead and depolarizes the atria. The atria pumps the blood down to the ventricles, and this travels through the AV node. Once the ventricles get filled up with blood, the Purkinje fibers carry that electrical charge down and out to the back. It's kind of like a W. So it goes from here to the middle, and it makes its way down to the bottom, and that's when the contraction occurs. So it pushes the blood upward. If it started at the top, then the blood would be pushed down and wouldn't know where to go. But instead, that charge makes its way down to the bottom, and then it causes that depolarization, which contracts the heart muscle and pumps the blood and out of the body. Out of the heart and into the body. Just know that that's the way, the order and how this occurs. So here we have who's responsible for what. So the Purkinje fibers, it's about 30 beats per minute. They're the slowest ones. Then we've got your AV node. It's at 50 beats per minute. It's like the middle pace. And then lastly, we've got the SA node at 70 beats per minute. So in normal heart rhythm, whenever a person is at rest, you're about 60 to 70 beats per minute. Your SA node is the predominant choice here. But if you were to have some kind of problem with your SA node, or you had some kind of condition, then your AV node would take over and try to maintain that rhythm. And at least you would have 50 beats per minute. If you had a further complication, some kind of systemic depression, or something that just went ahead and put you into a cardiac depression, and your heartbeat would slow down, and your Purkinje fibers would try to keep you alive. You might not be able to do much physical activity, but at least you're still alive. So here, the ECG, know what it's used for, and I don't know if they're going to include pictures in this exam. I doubt it, since the last exam didn't have any pictures, but they might ask just to gauge your understanding of the waveforms and how they each participate in each phase of the cardiac cycle. And essentially, the ECGs are used to diagnose heart problems in patients, and they use leads to pick up electrical activity. And whenever this electrical activity is picked up, different waveforms are represented on the ECG. And you can detect things like heart rhythm problems or conduction blocks, which we'll go over. Okay, this is key to understanding how the EKG works. It's not picking up individual cells, the actual potentials of individual cells. It's picking up the whole population of cells in that general region of the heart. So know that the P wave would be HO depolarization. That's the general area. It's not a specific cell in that area. It's these EKG leads are picking up outside of the heart and around the body. They're connected to different sides of your chest and down at the bottom here on the side of your ribs. Then they're not directly picking up electrical signals from that component or that specific cell. They're picking it up from outside the body. That electrical conduction has to travel very minor inflection points, which causes these peaks on the EKG. Here we break it down for you. Each one of these, this is the general waveform that you'll see. You got the P, QRS complex, and the P wave. Know which one does what. So here we go to the P, and the P wave is for HO depolarization. If you're following along, try to guess what QRS is for. You don't have to blurt it out, but just try to see if you understand this before I show it. So the QRS complex gives you an upward deflection associated with ventricular depolarization. And lastly, the T wave is going to hit you with ventricular repolarization. I hope y'all are following along. Okay, heart rate. Again, I don't think they're going to include any pictures, but you would want to know that if you had, for example, like multiple P waves or T waves, what kind of condition that might be referring to, or if the R to R peaks. This is actually how we detect heart rate. You measure the distance between the heart rate, between the two R's, QRS complexes. So these peaks, and you try to see how far apart they are, and then you can determine the heart rhythm. If these peaks were closer, then that would be considered tachycardia. If they were further apart, then that would be bradycardia. And then there's a multitude of conditions that might show, like, for example, on my worksheet, I included an elevation between the S component and the T wave. And that's actually, it would look something like this. Okay, so you would, I don't know if you can follow along with my laser here, but an ST elevation is actually a clear sign of myocardial infarction, which is a heart attack. And oftentimes they use that for diagnosis purposes. So even though they're not including pictures here, they might verbally put it in words on an exam. If you had this kind of elevation, or if you had multiple of these type of waves, or if the R to R were closer, what would that be referring to? So fibrillation is when the heart is out of whack. It's feeling fuzzy, I like to think. So it's not doing what it's supposed to, and the beat is no longer in rhythm. This involves the electrical activity. So in atrial fibrillation, it's going to be the lack of the synchronized depolarization of the atria. So they're beating out of rhythm, but luckily your ventricles are still able to pump that blood to the rest of your body. Whereas the ventricular fibrillation, if your ventricles are not beating the way they're supposed to, then that's a big problem. And when either of these two conditions occur, oftentimes you have to reset the heart using something, AED. Okay, I don't think this is going to be on the exam, but this is actually something that we use in medicine to try to remember how the heart rhythm, which conduction block problem is happening after reading an EKG. So put this in there for you. I don't think you need this. All right, another short break if we have any questions, but we're about halfway through my section.
Very quickly, sir, could you restate about T waves effect on myocardial infarction? Did you say
sure.
that I don't remember if we did that in class. So could you just
I'm not sure if we did, but basically, if this is the QRS, okay, and here's your T wave. So what it would look like is your S would actually be higher, and then your T would be here, and it'll make its way down. So this is called an ST elevation, because the point between S and T is raised. S didn't make its way all the way down here. Instead, S is here, and then it proceeds onto T. It looks like S and T are like a nice plateau, and then T makes its way down. So an ST elevation is a way that we diagnose myocardial infarction. And I included a picture of this and a question on my worksheet in this section of the lecture, if you wanted to review that. I don't think they're going to include pictures, but it helps you understand how the heart works, not on the different waveforms, and which part of the cardiac cycle is affected.
Thank you very much.
Yeah, no worries. So, so this little cartoon on the left helps you understand the blood flow. I just like to repeat this over and over until I get the general overview of how the blood travels throughout the heart, and then eventually out to the body. So here we've got, this is lecture 10B, for everybody that's following along. These are the topics we're going to cover. And cardiac output, this is going to be a big one. Cardiac output, they can hit you with different factors that affect cardiac output. Just know the big component of cardiac output is heart rate, stroke volume, determine cardiac output. So if something affects stroke volume, know if it would increase stroke volume, and then know that the relationship between stroke volume and cardiac output is cardiac output would also increase. And additionally, it increases heart rate. So there's a number of things that can increase either stroke volume or heart rate, but know that either one of those are going to increase your cardiac output. Understand that relationship, and then know how stroke volume is determined. And this is by the end diastolic volume minus the systolic volume. They included this in the lecture notes. Know this, because this is something that they're going to play with. It's very easy to get tripped up on questions. Know that, like I mentioned before, something increases heart rates and increases cardiac output. And oftentimes, when you want to increase heart rate, it's sympathetic innervation. Something like epinephrine is going to come in, speed up your heart rate, increase your cardiac output. Cardiac output is how much blood is pumping out of your heart and the rest of the body. Okay, so autonomic control. There's different, the different systems are going to be competing, and if you're relaxed or if you have parasympathetic innervation, essentially, it's going to decrease your heart rate. Sympathetic would do the opposite. So if you increase your heart rate, then you've got more blood pumping out to the rest of the body, and that in turn increases your cardiac output. You have more blood pumping out to the rest of the body in a shorter window of time, then your cardiac output is increased. So this would be the action potentials and how they're affected by parasympathetic stimulation or sympathetic stimulation. If you had sympathetic stimulation, then that would increase your rate of depolarization, and that means that you would see more peaks in a shorter window of time. The opposite for parasympathetic, you would have less peaks in the same amount of time. So either stretch out the amount of peaks you have in that amount of time, or you increase the amount of peaks in that amount of time. And this refers back to the depolarization events and know which ions are participating. Know that first diagram I showed with the action potential, know which ions are participating in each component of the action potential. They might do one of those questions. I know for sure I saw that on mine. Frank-Starling mechanism, it sounds more complicated than it is, but basically something either increases or decreases the stroke volume, and there's so many things they can ask, but you don't have to know this, like there's no like specific component. They'll kind of give you like a scenario-based question that's basically telling you that the cardiac output is increasing, and then it's going to be increasing by stroke volume or again by heart rate, and it could tell you something like this person ran a mile, their heart rate is increased. How was their cardiac output affected? Did it increase or decrease? So scenario-based questions would help you understand that. This is for your own study purposes on your own time. I'm not going to just read it out to you. You can read that on your own. But there's different factors affecting stroke volume. So a graph like this is a better representation showing you how extrinsic and intrinsic control are ultimately affecting stroke volume. And then stroke volume again participates or is a key factor in determining cardiac output. So you're going to see probably multiple questions on cardiac output and how the other factors affect cardiac output. Some useful stuff I throw in here. Know which valves are closing and making the lub down or the dub down. This also helps you understand what part of the cardiac cycle you're in. You've got lub happening, know which valves just closed, and then where the blood flow is going to proceed to next after it's made its way through that part of the valves. And here I include systemic arterial blood. It shows you what percentage of blood in a normal resting human is being received by each one of these organs. And then, of course, if you were to increase your heart rate or your cardiac output, different factors would cut off circulation or at least reduce the amount of circulation or blood that's being reverted to a certain organ. So if you were running a mile, you don't need to digest, so you would have a decrease in blood flow to the organs. And instead, you would increase blood flow to the heart and your stroke. So you only have, let's just say 100% of your blood, so you have to divert blood flow to different organs or different regions as needed. So this is the last lecture I'm going to cover for you guys. And girls, of course. Blood flow through the circulatory system, the way it operates, it's just like all fluids work, high pressure to low pressure. They're probably going to hit you with one of those questions. I included one in my worksheet as well. It basically gauges your understanding through a numerical value of if you had X amount of pressure on one end and Y amount of pressure on the other, what would be the pressure difference between the two? And now they can give you an ABCD multiple choice question where you have different values for each one of those. And always, no matter what, even if you had 100 pounds of pressure, let's just call it 100 millimeters of mercury on X and 80 millimeters of mercury on Y, that might be a higher value than 60 and 20, but the difference between the two is greater for the lower values. 60 to 20 is a difference of 40. 80 is a difference of 20. So the difference of 40 is greater, meaning the pressure gradient is greater. So you would have greater flow if you have a greater difference between the two pressures. It doesn't matter what the numbers are, just know that the difference between the pressures will matter. And then here's a nice diagram that shows you where the pressure is greatest. And if you follow your way out of the aorta, which is the highest pressure, you go down to arteries, arterioles, capillaries, all the way down until you make your way to the vena cava and back to the heart. So I mean, this for you guys is similar to the one that's included in the lecture, but it's kind of like an animation. So flow rate would be the volume of fluid that this blood cell, let's just say all these blood cells are traveling through this particular point. I drew a line for you. And then however much makes its way through in a certain amount of time is flow rate. And then for flow velocity, it's going to be how much the distance is going in time. So we give it like 5 millimeters here, just for example, and how much that how much is traveled within in the same amount of time, let's call it. And then I gave 2 examples here, and this is very simple. Just know the difference between the 2. It shouldn't be something that can trip you up. You should be able to get this pretty quickly. So know that the effect that resistance has on pressure, know that how radius affects this. Basically, they're all interconnected. And if you were to have an increase in resistance, then you would have less likelihood of flow. And if you have low resistance, you'd have greater flow. And that's essentially due by narrowing the tube. So if you narrow the tube, then less liquid can flow through it. Okay, if you make the tube wider, then more liquid can flow through it. It's pretty straightforward. Okay, so this is the mathematical relationship. I don't think they're going to give you a mathematical based question, but you can actually interpret this as if the resistance is greater, since it's on the bottom, then you'd have less flow. So for anybody who's a math buff or they like this kind of stuff, know that the inverse is true as well. So if resistance, so if flow is less, then resistance is greater. I hope that's not confusing, but I included a little memorization. In this scenario, we've got an artery that's becoming more narrow, or essentially the radius is getting smaller. And if the radius is getting smaller, what effect would we see on the resistance? Anybody can blurt out the answer. Or type in the chat. So smaller radius, what effect would we have on resistance? And yes, I see some correct answers here. So yep, you're correct. Smaller radius is increased resistance, and essentially that leads to high blood pressure. We're trying to make those connections, okay? Good. So flow velocity is, again, going to be how fast the blood is traveling through this tube, and you have an increase in velocity when the tube is smaller. That's because the same amount of fluid is trying to make its way through a smaller tube. And because it's smaller, then more fluid is making it through that tube. If you had a larger tube, the same amount of fluid is trying to make its way through the tube, but there's more tube. It's a little bit confusing, I guess, if you kind of think of it that way. But the smaller the tube, the less it has to, less amount of material has to flow through it. That essentially it's coming out faster. And then know the relationship between cross-sectional area and how they affect things like blood pressure and velocity. So this is a key one. Your cross-sectional area is greatest at the capillaries, which means lowest velocity. And this is important because this is where gas exchange occurs. You would definitely want the velocity to be the lowest at the capillaries. That way, your red blood cells can go ahead and can pick up oxygen or pass off oxygen, because this is where the exchange occurs. So your blood cells would give off oxygen to the cells and pick up CO2 and then take it off to the rest of the body, to the veins and then back to the heart. So then it can be removed from the body. They included this here with the different diameters for the blood vessels. They might ask a question on blood vessel diameters and which cells are participating in each one of these vessels. Might be important, but these little graphs here help an understanding of what's happening here. Okay, so know that the arteries are elastic, and this is what leads to that keeping that pressure and keeping that blood flowing throughout the body. Once the blood has left the heart, then it makes its way through the arteries expand, and that pressure is stored there. And then when that pressure is stored, since it's pushing outward, eventually it comes back in, it pushes in, and pushes that blood out to the rest of the body. This is what's keeping your blood pumping throughout your body. So know these pressures, know the difference between pulse pressure, mean arterial pressure, how they're calculated. Here, include the little equation. It's easy to think about if you just use this one right here, very easy. They most likely will hit you with a number like this. I mean, a problem like this that includes a calculation because it's very easy to trip you up. I know that shame on me for taking the exam and I wasn't prepared and I missed one of these math questions. It's just 2/3 of diastolic and 1/3 of systolic. And the reason why diastolic is more important is because we spend more time in diastolic. But just know this. If it's a math question, it's going to be a simple math question. It's not going to be anything complicated. It'll be something you could do off the top of your head. And definitely know the difference between diastole and systole. Contraction is pushing that blood. Diastole is relaxation and filling with blood. So here we get to blood pressure. They included this diagram in the lectures, and I like the way it explains things. It is basically telling you how we measure blood pressure. And what we use is we cut off the circulation, then that way there's no sound present. We slowly release, and this opens up the vessels, and then that way the blood can travel through. That first sound you hear is that systolic pressure, and then eventually your blood vessel opens all the way until it's no longer making noise. And when it's no longer making noise, that's your diastolic pressure. It's common to see a value of 120/80 as considered normal. You can have a range of values, could be like 110/70, or it could be something like 1.5. But beyond that, you start to get into pre-hypertension and then eventually hypertension. You're trying to keep those values somewhere around 120/80, but it is dependent on things like your size or your age. And always know that the systolic is on the top and diastolic is on the bottom. And make sure if you're given about some of these values, like if you were given 120/80, that you can calculate the mean arterial pressure. All right. One-way flow of the veins, because veins do eventually have the lowest pressure in the body before making their way to the vena cava and then back to the heart, then what is preventing the blood flow from going backwards? And it's going to be those valves that we mentioned. So the valves throughout the cardiovascular system or the circulatory system are going to be preventing that flow. So when you're walking, running, or doing some kind of physical activity, you're moving, the blood is being pumped through your muscles, through the vessels between your muscles, and it's basically forcing that blood to go forward to the rest of your body. Okay, the other one is the respiratory. And this one here, when you breathe, you're creating low pressure in your thorax region, where your lungs and your heart are. That low pressure, bringing that blood towards the heart. Anytime you have low pressure and high pressure gradient throughout your body, anywhere in your body, you have a concentration gradient or pressure gradient, those are going to determine the flow of things. This is something that you should review for your final exam. You should make sure you know that concentration or pressure gradients are what make the flow of things happen throughout your body. An ion concentration that's greater, if you have a pressure concentration that's greater, that's going to be the driving force of things in the forward direction. So in this case, you have lower pressure in your chest cavity. Lower pressure is going to draw in that higher pressure to bring it into that lower pressure region. And lastly, we have the sympathetic changes in venous tone. This is going to basically open up the vessels or close the vessels, and these are going to determine where the blood flows to a particular region, or just basically pushing the blood. Okay, so these are the control mechanisms. This is one that they talked about for a bit. I think Dr. Lutterschmidt was mentioning this. So essentially, tonic activity is saying that you have constant activity here for norepinephrine constantly being released. But if you have more norepinephrine or if you have less norepinephrine, these are going to determine your blood vessel dilation. So if you had an increase in norepinephrine, it'll constrict your blood vessels. When do you see an increase in norepinephrine? Commonly, it's when you're exercising or doing some kind of physical activity, and that's going to constrict your blood vessels, and that's going to increase your blood pressure. Understand all of those relationships. Increased blood pressure is caused by constriction or narrowing or smaller radius of the blood vessel. All of those are the same thing. They can use any of those words, but they all essentially mean the same thing. Here's just a summary table for you all to review, and it's got a series of what's essentially going on and how they all relate to blood pressure. A big one is going to be blood pressure, because you can make it to the stage where heart rate, stroke volume affect cardiac output. And cardiac output, how it's basically the way that we measure blood pressure. We use cardiac output to measure blood pressure. So if you had a decrease in cardiac output, you'd have a decrease in blood pressure. All of these relationships are important to know these relationships. And I think that's going to conclude my slides. So I got one more for you to hopefully brighten up your day. So who's been causing all the trouble lately? Of course. And this is the real face of cardiovascular disease. All right, everybody. I got some questions for you. Feel free I think my co-tutor is going to help me do this. If you have any questions, of course, feel free to ask some questions. Let's see. There you go. All right, so there's a poll for you. Please do your best to answer these questions. I'm going to give you about 15, 20 seconds for each question. Yes, it's a little bit of time, but I want to get you ready for that exam. So do your best, please, real quick. I'll give you another, so this one's a thought-invoking question. We're going to give you another 10 seconds. Just give it a good guess. We can review the answers later, or you can ask questions later. Slides are going to be made available to all of you later. All right, I think we're going to wrap it up. So you guys went with A, and I'm sorry. Is it sharing? Yeah, I think it's sharing. Okay. Cool. So, I'm sorry, it's not A. What is the correct answer? It's E. Okay. I threw in a trick here. Revert back to the slide where I show you the graphs, and that'll help you. If you still don't get it, drop a question or stick around. Okay, so go ahead and do your best to answer this question. I know I ran through a lot of the material really fast, but I can do my best to explain everything at a later time. All right, another 10 seconds. Okay, somebody went with E, good job. I'm kidding. Somebody was paying attention. I see a good number of you are paying attention, good job. All right. Oops, what happens here? All right, next question. When is the ventricular blood volume high? I meant to say highest, but yeah. Ventricular blood volume highest. Should get that song. All right, another 5 seconds. I don't know if my co-tutors are handling the question polling stuff. All right, I don't know if they can post the result. I'm not seeing anything. All right, and you guys are correct for the most part. I see an even split between A and B. For those of you that chose B, so if you have a question on that, or if any of you have any questions on any of this, feel free to ask all over. All right, which of the following is not true for the ventricular systole? This one's going to be 10 seconds only. You should know this off the top of your head. It should be fast. All right. 5 seconds. Cool. And it looks like most of you got a good job. Again, systole, remember the ventricles are pushing blood to the rest of the system. I like to think of it. They're working hard. They're not going to be chilling. All right, semilunar valves close. See if people can on the cardiac cycle. All right, another 8 seconds or so. Yeah, this feels rushed. I'm sorry, but we're trying to like run through all these slides, and then you can always ask questions later. All these slides will be available to you later. All right. Most of you were wrong, and we can talk about that later if you want. Early diastole ventricles are relaxed. The blank valves snapshot to prevent that. Okay. How did we do? Looks like you guys had a unanimous, or for the most part, B, and that is good job. And don't feel discouraged for all of you that got the answer, any of these answers wrong. This one I'm actually going to give you more time for. Hold on real quick. If you got something wrong, that's really my fault as a tutor, or maybe you didn't prepare as much as you'd like, or maybe something was very confusing. And if that's the case, then I want to be able to help you understand it. So this is just to gauge your understanding in a short amount of time to see how prepared you are. The kind of questions that you get wrong are the kind of questions you should be reviewing for the exam. And remember, this isn't an anatomy exam, it's a physio exam. So it's not going to be, did you remember the name of the atria or the valve? It's more like which valve participating in what, or what part of the cycle. So let's see what we see here, and C is good. Oh yeah, that's almost all of you. Good job. I'm very proud. All right. Increase in end diastolic volume leads to yeah, we have a few more questions and now we're going to transition to the next co-tutors. So I hope you girls are ready. All right, so we'll just end the polling. We've got B. Good job. We're paying attention. Okay, this will be a quick one. I'm gonna give you 8 seconds. And go. Come on, I believe in you. Let's see how you did. Oh, B, good job. Okay, T wave. Definitely know the waves. All right, another 5 seconds. And C, good job. All right, cardiac action potential. This one might be a little bit more tricky if you don't have the graph in front of you, but let's see if you can pick it up from memory. What do you think is open at the very peak of the cardiac cycle? So remember how the cardiac cycle has that that waveform. There you go. Oh, I kind of ended it early, but yeah, for the most part, you guys got it. Good job. You guys are ready for your exam. Good job. And I think this is my last question. Yeah, that's my last question. So asking for cross-sectional area. And if you recall, I gave you a nice example. Remember this. All right. Go ahead and close the polling. And good job. Cool. So that's it for me. Thank you for your time. Thank you for hearing me out. And I'm gonna hand it off to my co-tutors. Good luck.
Awesome. So I think I'm up next. Welcome everyone. I'd like to say thank you, first of all, for coming out here on a holiday. We definitely appreciate it. So I'm going to be covering lectures 12, 13, and 14. So lecture 12 is going to be about blood. So let's get started. Okay, so we're going to talk about types of capillary exchange. So there's 2 different types. So the first thing we're going to talk about is continuous capillaries. And by far the most common capillaries, or the most common type of movement, is going to be through paracellular diffusion. And that's the transfer of substances across an endothelium by passing through the intercellular space between cells. So that's basically going to be cells literally passing their material through the endothelium. And that's going to be for smaller substances. Now, transcytosis is going to be for larger molecules like macromolecules, for example, or proteins. And that's basically when these molecules are going to pass through the interior of the cell from one end through vesicles, and they're going to be like exocytosed from the other end of the endothelium. And you can see a little graphic of this. So kind of think of it as like when vesicles release their neurotransmitters and action potentials. Is kind of the same idea, except that here we're talking about transport. Moving on. So the second type of capillary exchange is going to be through fenestrated capillaries. And this is mostly seen in the intestines and the kidney. So this is a form of transcytosis, but what we see is that the endothelium, basically, we have these large pores that are created. This allows for larger items to pass through. So it is transcytosis, but it's localized to the intestines and the kidney mostly. So with capillary transport, usually the reason why we have materials being transported is that's going to be due to bulk flow. Okay, so bulk flow is what drives capillary transport, and bulk flow is basically the movement of fluid due to pressure. So everything in your body moves based on the concepts of pressure and volume, and this is no different. So fluid will move from areas of high pressure to areas of low pressure. And so what we have here is a graphic showing the arterial end and the capillary end. And what we have driving the fluid movement is hydrostatic pressure and osmotic pressure. And hydrostatic pressure is the pressure that is exerted out of the capillary. It forces the fluid out of the capillary. And osmotic pressure kind of opposes that, as you can see from the opposing arrows. The osmotic pressure is the red arrow and the hydrostatic pressure is the blue arrow. So they'll actually oppose each other because the osmotic pressure wants to draw fluid in, but hydrostatic pressure is going to want to draw fluid out. And so what we have on the arterial end is going to be a net filtration of fluid. And then what we have on the capillary end or the venous end is going to be a net absorption. So just kind of keep that in mind. This might be a test question, is kind of like what do we see on the venous end of the capillary? And that's going to usually be a net absorption, and then vice versa for our the arterial end. So the baroreceptor reflex is something that Jose kind of touched on in his discussion of tonic control in the sympathetic nervous system, but I'm going to go into it in a little bit more detail. So the baroreceptor reflex is basically the way that your body mediates its blood pressure. So it's under autonomic control, and the purpose of the baroreceptor reflex is to maintain a homeostatic constant blood pressure. And so it does that by regulating the sympathetic and the parasympathetic branches. So imagine, for example, you are walking down the street and all of a sudden you get attacked by a bear or something. And so that's going to trigger an increase in the sympathetic nervous system, and it's gonna drive your blood pressure up, and that happens through the baroreceptor reflex. So what happens is the carotid and the aortic baroreceptors, they will stretch, and that'll signal to the medulla oblongata that we need to increase the blood pressure. And so that'll then trigger an increase in sympathetic activity. So that will be like an increased heart rate, an increased force of contraction, cardiac output, and then arterial vasoconstriction. And all of these things are going to result in your blood pressure increasing. And so you're going to have an increase in sympathetic activity and also a decrease in parasympathetic activity. So these two branches are pretty much antagonistic. So they'll balance each other out in order to mediate your blood pressure levels. So I have a little question here. I'm gonna activate the poll or launch the poll now for you guys. Take a few seconds to answer. Okay, I'm gonna stop it now. Jose, if you could reveal the right answer. Oh. Yeah, yay. Yeah, you guys got it. So the right answer is increased cardiac output. Good job. So atherosclerosis is a disease where basically your arteries are clogged up. And that's going to be due to like fats and cholesterol clogging up the arterial walls. So it's going to be the buildup of plaque in the artery wall, and it can actually be deadly over time because it'll restrict the blood flow. And so what happens is you have fatty streaks forming on the arterial wall endothelium. And so that will cause these macrophages to come and consume this excess LDL, this low density lipid, and that'll then trigger the release of enzymes that will expose collagen. And the presence of collagen is needed for platelet formation. So without collagen, your platelets can't form, and so you can't have coagulation. But because these enzymes were released, that'll expose collagen and that'll attract platelets, and these platelets will form a plug in your artery walls. And over time, this will cause calcifications to form, which reduces the compliance of the arteries and it makes them less elastic, and it can lead to death later down the line. So we're going to talk about red blood cells. So erythropoietin, not sure how you say it, is synthesized by the kidneys, and it's a protein that stimulates red blood cell maturation in the bone marrow. So the bone marrow is going to be your site of pretty much all blood cell production, whether it be white blood cells, red blood cells, that all happens in the bone marrow. And so erythropoietin is going to be a really important protein for stimulating the maturation of red blood cells. And so red blood cells are unique in that they have a biconcave shape, and they also lack a nucleus. So this is one of those examples where structure determines function. So their structure is actually really important in facilitating oxygen transport and smooth flow through the capillaries, so they can actually kind of conform their shape in order to be able to move throughout the body. And then the lack of nucleus also adds to their flexibility in their movement. So we're going to talk about how iron gets onto hemoglobin, because that's one of the most, I think, important topics. So hemoglobin is an oxygen carrier. It's the primary oxygen carrier. About 98% of the oxygen in your body is bound to hemoglobin. And so how the iron gets onto hemoglobin is, so the DMT1 is a channel protein on the enterocyte, and the enterocyte is just the intestinal cell, essentially. So DMT1 will transport an iron molecule into the enterocyte. And then FPT is like a transfer protein. So it'll allow the transfer of iron into the blood. And so once it's in the blood, iron can bind to transferrin. And so transferrin is then going to transport that into the bone marrow and onto hemoglobin. And if you can see here in the diagram, the transferrin facilitates the movement of the iron into the erythroblasts, and erythroblasts are basically like immature, like red blood cells, essentially. And so the binding of iron onto hemoglobin is one of the most important steps in red blood cell maturation. So blood metabolism. So one of the most important structures in your body is the spleen, and the spleen is basically like a regenerative organ. So it'll destroy old red blood cells and it'll recycle iron, and it also stores excess red blood cells. And one byproduct of heme breakdown is bilirubin, and bilirubin is actually a toxin that needs to be eliminated. So once it forms, it's sent to the liver and the kidney, to be eliminated, but if too much bilirubin is formed and the liver is not able to eliminate it, that causes a disease called jaundice. And so we see this most commonly in children, and it's because it happens in the transition from infant hemoglobin to adult hemoglobin. And usually we can treat this with blue light. So there is treatment out there for this disease. So anemia is a deficiency in oxygen carrying capacity, and it causes tissues to not work optimally. So we often see this in people who have low iron, or like an iron deficiency, and it's caused by a low hematocrit. But we can think of it more broadly as just a deficiency in oxygen carrying capacity. So some symptoms of anemia are fatigue, exercise intolerance, and weakness. And then we also see a range of mild anemia to very severe anemia, and it can also be short-term or long-term. So thrombopoietin is also a protein, and it's synthesized by the liver. And it stimulates megakaryocyte, which are platelet-producing cells. It stimulates their synthesis. And so platelets are very important in that they essentially, they're needed in case there's an injury or like the endothelium is no longer intact. So they can sense that and they will quickly go to that area of injury and they'll form a plug. So I'm gonna just quickly go over the steps of how this happens. So once an injury is triggered, the collagen, remember the collagen that we talked about earlier, it's this protein, and it'll kind of like aggregate around the injury site, and it'll bind and it'll activate the platelets. And it'll then release platelet factors, and then these factors will attract even more platelets, and eventually all these platelets will gather together to form this plug. And so one important point I wanted to say here is that if you can see here on the left side of the figure, the intact endothelium releases prostacyclin. And so prostacyclin is released when the endothelium is intact. So I had a question about this in one of my worksheets actually, and I can see this being a good test question is, how would the body know if there's already collagen around the endothelium, how would it know not to form platelets, right? Because collagen is needed for platelet formation. And that's going to be because of these prostacyclins that are only present when the endothelium is intact. So in the case of an injury, they're actually not intact, right? So that's how collagen is able to trigger platelet formations, because of the absence of prostacyclins. So that's an important point to keep in mind. So coagulation and fibrinolysis. So coagulation is essentially platelet formation. And so what happens is fibrinogen is the inactive form of fibrin, and fibrin is what will form the blood clot. So fibrinogen gets activated into the fibrin polymer by thrombin, which is another protein. And so once the clot forms and the injury heals, fibrinolysis is what degrades these fibrin polymers. So we have fibrin polymers being broken down by plasmin into fibrin fragments. So we go from coagulation to fibrinolysis. Coagulation when there's a site of injury, and then once the injury is over and the body has healed, we can now dissolve the blood clot through fibrinolysis. Okay, so now we're going to talk about the airway branching system. So we start off from the trachea to the primary bronchi, smaller bronchi, bronchioles, respiratory bronchioles, and the alveoli. And so the conducting system is made up of the first four, and then the exchange system is made of the last two, okay? So an important point to actually keep in mind is as we go down the respiratory system, we have more and more branching. Okay, so we start off at the trachea where there is absolutely no branching, to alveoli where there's a lot of branching. And that branching is important for cross-sectional area. So the alveoli have a much greater cross-sectional area than, say, the trachea. And so this is beneficial for gas exchange later on when, which we're going to talk about in more detail. But there's, again, this kind of structure function thing going on where the alveoli structure dictates their function. Okay, so we're gonna talk about more on the airway epithelium. So this is the basically what the inside of the trachea looks like, and it's made of these columnar epithelial cells. If you can see them, they're kind of these long. I wish I had the pointer on my end, but they're kind of like the long yellow cells. Yeah, there we go. So these are essentially the building blocks of the trachea, right? And so what happens is we if you can see here, the ciliated parts right here at the end of that, they're kind of the hair-like projections. These are called cilia. And so the function of cilia is they'll actually transport the mucus up into the pharynx in order to secrete any dust particles or anything that needs to be discarded out of the respiratory system. It's gonna go up with the mucus. And so what kind of loosens this mucus and helps it move up is this watery saline. So think of it as like if you're trying to like mop the floor, but like you don't have enough water, so you're not able to like get rid of the dirt. It's kind of the same thing, right? So without the watery saline, the mucus is going to be way too thick and gloppy, and it won't be able to transport it up the cilia and out into the pharynx. So the saline is very important, and we'll talk in a minute about a disease where we have this function in saline, which is cystic fibrosis, and that causes a very sticky mucus. And so that can actually be a very a lethal pathology later on, because then what we end up is these very bad lung infections. So I'm going to quickly run through the steps of what happens at the airway epithelium and how we actually form this watery saline. So the first step is we have these channels called the sodium potassium 2-chloride channels, the NKCC channels. These will bring in a chloride molecule into the epithelial cell. And they'll bring it from the extracellular fluid. And this is mediated by ATP pumps, actually. And so the apical anion channels, like the CFTR, these allow the chloride to enter into the lumen, which is on the left side, so the apical membrane. And so once the chloride enters, we then have an electrogradient forming because we have a lot more chloride forming on the apical side. And so we have a net negative charge on the left side. And so that's going to prompt the transfer of sodium from the extracellular fluid into the lumen through the pericellular pathway. So it will basically go down in between the cell, in between the two epitheliums and into the lumen side. It's going to go down its electrochemical gradient. And so that's going to then trigger the flow of water because then we have an osmotic gradient, right? Water flows, if you remember from the very beginning, water flows into areas of high solute concentration. So the osmotic gradient is going to trigger water to go over to the lumen side. And so that's essentially how we have this watery saline forming is it's really spearheaded by these CFTR channels. And so when we have a dysfunction in these channels, we're not able to form saline. So I just talked about this. So cystic fibrosis is a disease caused by a mutation in the CFTR channel and the airway epithelium. So what effect do you guys think this might have in individuals with this disease? So take a few moments. I'm gonna relaunch the poll. Okay, I'm gonna end the poll now. Okay. Yeah, good job. So we're not going to have the ability to produce watery saline, making for thick mucus that disables cilia movement. So what we see oftentimes is the cilia will actually get stuck. And so we'll have this kind of like mucus, like this kind of thick lungs that have mucus trapped in them because they're not able to generate any saline. So moving on. So these are some factors that influence diffusion just in general. So an important concept here is fixed law of diffusion, which I know Dr. Lutterschmidt kind of talked about. So what we have is the rate of diffusion is proportional to the surface area times concentration gradient times membrane permeability, and is inversely proportional to membrane thickness. So essentially, the thinner the membrane, the cell membrane, the higher the rate of diffusion and vice versa. So again, concentration gradients also affect the rate of diffusion. So when you have a greater concentration gradient, you're going to have more efficient diffusion. Lipid solubility, we know that more lipophilic or like more lipid molecules are able to cross the barrier much more easily than hydrophobic molecules. Same with molecular size. Large molecules aren't able to diffuse as easily as small molecules. So these are just a few factors. One thing to keep in mind is that pressure gradients and not concentration gradients are what drive gas diffusion in water. So in fluid, which is what we're going to talk about next, we have pressure gradients defining gas diffusion and not concentration gradients. So we have this kind of mechanism in our body that allows us to carry oxygen which is hemoglobin, because oxygen is significantly less soluble in water than carbon dioxide. And so Dr. Lutterschmidt really made it a point to kind of go over this part in detail and kind of explain why we need hemoglobin. And it's essentially because oxygen is very bad at dissolving in water compared to CO2. CO2 is very dissolvable in water. So oxygen is not able to diffuse throughout the body on its own, which kind of presents a problem because we need oxygen to be uptaken by our tissues in order for us to go about our daily functions, right? So notice how, just from the figure, the blue dots, CO2 is much more soluble than oxygen is, and it can react with water to drive acidity or alkalinity. And this equation, CO2 plus water, forms bicarb, which forms HCO3 minus plus a proton, is going to be one of the most important equations to keep in mind going forward. It drives a lot of the reactions in the body, ones that we're going to talk about now and ones that we won't talk about, but it's one of the most important equations to keep in mind. And so CO2 is able to diffuse throughout the body on its own and kind of trigger these different pH changes, but oxygen needs a little bit more help. Oxygen needs hemoglobin to be able to diffuse into the tissues and go about doing its functions. Okay, so last lecture I'm going to go over is lecture 14. So we're going to talk about pressure gradients briefly. So the important thing to take away from this slide is that pressure gradients are kept constant. Okay, so partial pressure gradients are what drive gas exchange. So we're always going to have these concentrations maintained in the alveoli. So PO2 in the alveoli is always going to be 100 mmHgs. And then for PCO2, it's always going to be 40. And for peripheral tissue, we're always going to have a PO2 of 40 and then the PCO2 46. These are just constant values that are always maintained. And then note how the concentration gradient here for CO2, I kind of circled it on the right, but note how the concentration gradient for CO2 is much slower than the concentration gradient for oxygen. And that's because CO2 is much much more soluble than oxygen, so it doesn't need a concentration gradient that is that big to be able to kind of be effective and go about inducing the changes in the body, whereas oxygen does need a big difference in concentration. I'm gonna quickly just run through the next few slides because these are definitely things that you guys can review on your own, but these are a few pathologies affecting gas exchange that are gonna be really important because it's very testable material. I remember when I took Dr. Azizi, I had quite a few questions about these different pathologies. So they're kind of easy points, just kind of memorize what the characteristics of each lung pathology and you should be good to go. But really quickly, emphysema is caused by smoking. We have basically these macrophages releasing elastin degrading enzymes, and so that triggers a decrease in lung compliance. So the alveoli are able to stretch, but they're unable to recoil, and so we have is stiff lungs because the surface area of the alveoli is greatly reduced. Next one is fibrotic lung disease, and an example of this that we talked about is cystic fibrosis. We have a scar tissue that forms due to regular infections, again caused by lack of saline. So this results in slower gas diffusion, and then the partial pressure of oxygen in the lungs is normal. Eventually becomes low, but starts off being normal, and then it's always low in the blood. So pulmonary edema is the retention of fluid between the alveolar wall and the endothelial wall of the capillary. And so this will increase the diffusion distance, and it will kind of mess with normal gas exchange, right? So we're gonna have slow, inefficient gas exchange because of this barrier between the alveoli and the capillary. And so this may be caused by an increase in pulmonary pressure. So the high hydrostatic pressure, it'll drive fluid out of the capillary bed, and it'll cause retention of water between the capillaries and the alveoli. And so what we see is that the PO2 is normal in the lungs, but it's low in the blood. I believe this is the last pathology that we're going to talk about, and it's asthma. And it's when we have the bronchioles constricted, and so we have a problem breathing out in asthma. We call that obstructive disease. So we have a problem breathing out because our bronchioles are constricted, and so each new breath will mix with old air. And we also see an increase in airway resistance, and so that'll decrease the rate of ventilation in the alveoli. And again, we have PO2 that is low in the lungs and the blood in asthma. So I have another question for you guys. Take a few minutes and see which type of pathology this could be. Okay, let's see the answer. Okay, so the answer was emphysema. I'm not sure if all of you got that, but if you have any questions regarding why that's the answer, feel free to ask me after. Okay, so hemoglobin, kind of touched on hemoglobin, but we're going to talk a little bit more about the characteristics of the protein. So hemoglobin is a tetrameric protein. So that means that it's comprised of 4 subunits. It has 2 alpha subunits and 2 beta subunits, each with a heme group where iron is able to bound to it. So iron is always going to be bound to hemoglobin. It's kind of, that's just how it works, right? So hemoglobin greatly increases oxygen transport. So like I said, 98% of oxygen is going to be bound to hemoglobin because, like we said, oxygen is not very soluble in blood fluid, or just in the fluid in your body. So without hemoglobin, the body won't be able to meet its resting metabolic needs on top of drawing from its energy reserves. So we talked about how without hemoglobin, we might be able to kind of meet our resting metabolic needs just barely. But say, for example, you need to like go run away from someone that's attacking you, chances are you won't be able to do that without hemoglobin because you don't have enough energy to be able to tap into those energy reserves because you're not able to, your oxygen carrying capacity is way low, right? We're gonna need hemoglobin to attach to the oxygen to be able to help us draw from our energy reserves and be able to just like, I guess like, how would you say it? Capitalize on the functions of our body beyond just meeting our resting needs. So the Bohr effect is an important concept here in the discussion of hemoglobin. And it basically says that hemoglobin's oxygen binding affinity is inversely proportional to the to acidity, or so low pH and CO2 concentration. So that's to say that in situations where we have very low pH, the affinity of oxygen to hemoglobin is going to be low because oxygen is going to want to diffuse to those tissues. And we're going to talk about that, I think, in the next slide. So the oxygen hemoglobin binding curve. So we have when we have a higher affinity, we have a left shift in the curve. And when we have a lower affinity for oxygen, we have a right shift. So again, this occurs with hypoxic conditions. So hypoxic just means low oxygen. So say you're doing an intense exercise or you're climbing a mountain and there's a high altitude, there's a low pH, high PCO2, all of these things, high temperature, that will cause a right shift curve in the hemoglobin binding curve. And so that'll trigger the release of oxygen into the tissues. And then one other thing is when we do have these hypoxic conditions or anemic conditions, we have a presence in 2,3-BPG, which is an intermediate in glycolysis. And that'll also cause a right shift in this graph. Okay, sorry about all the questions. Hope you guys liked them, but just take a few seconds here. So yeah, this one has a few answers, so it's gonna make the full question, it's gonna be a bit hard to do the poll, but you can just reveal the answer. Yeah, so all of these things, anemia, intense exercise, high altitude, hypoxia, all of these things will cause a presence in 2,3-BPG, which will then in turn cause a right shift in the binding curve. So just a second here. Okay, so hemoglobin exhibits cooperative binding. And so what that means is when an oxygen binds to one subunit of hemoglobin, that triggers other subunits' affinity for oxygen to increase. And so think about this kind of, say like you're exercising, you're running on the treadmill, and so you need more, your body needs more oxygen, you need to kind of tap into your oxygen carrying capacity to be able to exercise your muscles. And so this cooperative binding is really beneficial because it increases the rate of the tissues uptaking oxygen. So if we were to just have a regular, you can see this from the graph, if you were to have no cooperativity in hemoglobin, we're gonna have a very slow release of oxygen into the tissues, right? So hemoglobin's cooperative quality is what increases the rate of oxygen uptake by the tissues. So yeah, allows for quick binding and release of oxygen depending on tissue needs. So a really cool thing is fetal hemoglobin. So fetal hemoglobin is different from normal adult hemoglobin in the biochemistry of it. So our normal adult hemoglobin is made of 2 alpha and 2 beta chains. Our fetal hemoglobin is going to be made of 2 alpha and 2 gamma chains. And one special thing about fetal hemoglobin is that its affinity for oxygen is much, much higher than maternal hemoglobin. And so this in effect causes it to steal oxygen from the mother to be able to cross its placenta and be able to regulate its own body functions. And so this is really important because if the affinity for oxygen were to be the same as maternal hemoglobin, the fetus would never be able to meet its own metabolic needs. So it's really amazing that our bodies have this mechanism where the fetus hemoglobin is going to have a much greater affinity for oxygen. That way, it can supply its own tissues and be able to survive in the uterus. So last protein I'm going to talk about is myoglobin. So myoglobin has an even greater affinity for oxygen than both fetal hemoglobin and adult hemoglobin. Has a much higher affinity. It's also a hyperbolic curve, so there's no cooperativity. Don't know if I mentioned this, but the curve for hemoglobin, I believe, is a sigmoidal curve, right? Which is what we see. It starts off slow, but then it kind of gets more and more steeper because it's cooperative. Myoglobin, we don't see that, so it's a straight hyperbola. So myoglobin is monomeric, so it's not tetrameric like hemoglobin, so just monomeric. It's good at releasing oxygen at low pH2 levels, so think about oxidative muscle fibers. Myoglobin is what actually gives them the red color, so it's going to be really advantageous for exercising those low oxidative muscle fibers and yeah, basically just give them their oxygen needs because they are highly vascularized. I believe this is one of the last things I'm talking about. It's not the last thing, but this slide was a little bit confusing to me. I remember when I was taking physio, so I'm gonna take a couple minutes just to kind of go through step by step what happens here. So here we talk about CO2 transport. So up at the top here, we have CO2 transport at the tissues, and at the bottom, we have CO2 transport in the alveoli. So about 7% of the carbon dioxide is going to be dissolved in your plasma. So that's the first arrow that you see here up at the top. That's going to be your dissolved carbon dioxide in your plasma. Now, about 23% also binds to hemoglobin inside the red blood cell. And so that's the first thing that you see here in the red blood cell, the HB times CO2. That's another 23%. Now that leaves us with 70%, and another 70% will actually get added to water and then make H2CO through carbonic anhydrase. So Ca, that's not California, it's carbonic anhydrase. So it forms H2CO3, and so that'll in turn form a complex of hemoglobin and a hydrogen proton. And one other thing that will happen is we'll have this chloride shift where the HCO3 minus will diffuse out of the red blood cell, and in turn, one chloride molecule will come into the red blood cell, and I'll talk about in a second why that's advantageous, why we need the HCO3 minus to be outside the plasma. And so what happens next is the dissolved CO2, it'll actually go down and it'll diffuse into the alveoli. So see here at the bottom, like the kind of purple side area, so that's the alveoli. So CO2 will diffuse into the alveoli because of the high oxygen concentration. And so then what we have here is a low CO2 concentration inside the plasma, because remember that CO2 just went inside the alveoli. So the way we combat that is the HbCO2 complex. That'll disintegrate into hemoglobin and carbon dioxide. And so the carbon dioxide inside the red blood cell, as you can see from the arrow over here, it'll diffuse out of the red blood cell, and it'll follow into the alveoli. It'll follow the previously diffused CO2 into the alveoli. So it's kind of this cascade where you have diffused CO2 coming into the alveoli, the CO2 and hemoglobin following it into the alveoli. And so then what we have here next, what happens next is that the oxygen in the alveoli, it'll drive the proton off of hemoglobin. And so once, so that's just called the Haldane effect. It's something that happens at your lungs. So it's when we have high oxygen in the lungs, it displaces a proton. And I have to apologize because I think I miswrote. I said displaces CO2. I'm gonna make sure to fix that before I upload the slides, but it's actually, it displaces a proton. And so you have proton plus hemoglobin forming, okay, in the red blood cell. So then when we think about what this might cause, this proton is now by itself in the red blood cell. And so that makes the red blood cell highly acidic. So what's gonna happen? The HCO3 minus that we just diffuse out into the plasma, that'll come back into the red blood cell. And bicarb is a buffer, right? So it'll balance out the acidity in the red blood cell. And so it'll come inside the red blood cell, and then one chloride ion will diffuse out. And so once chloride comes back, once bicarb comes back into the red blood cell, that will combine with a proton. It'll form carbonic acid. Again, our carbonic anhydrase will come in and speed up the reaction, and water and CO2 will form, and then that CO2 will diffuse out and into the alveoli. So it's just this cascade that forms over and over again. It's essentially how we're able to our tissues are able to uptake oxygen into them, and how we're able to then undergo this gas exchange at the lungs and take in carbon dioxide and replace it with oxygen. So it's going to be a cycle that happens over and over again. I know it's kind of a lot. It's a lot of like biochemistry, the slide, but again, if you're confused, I can always explain it again. I don't mind at all. I'm not sure if there's anything else that I have to say. Is there anything else, Jose? I think that was it. Yeah, so I'm gonna hand it off to Ariella next.
Hi everyone, just to reintroduce myself, I'm Ariella, and I'll be going over the last 3 lectures on this upcoming midterm. All right, to start off, we're gonna continue with the respiratory system. So pleural cavity. So this is just a thin fluid-filled layer that provides elasticity in the lungs. So it acts as a lubricant to reduce friction as the 2 layers slide against each other, and it helps to hold the 2 layers together as the lungs inflate and deflate, like a vacuum. And through surface tension, it's able to provide that force that keeps it inflated. Pneumothorax. So a pneumothorax is a collapsed lung due to air leaks in the pleural cavity, which indicates that there's a disruption in the subatmospheric pressure. And just a reminder, subatmospheric pressure is when it's a little bit more negative as opposed to the outside. So due to this issue, the pleural cavity will reach equilibrium with the outside environment and lungs. And this equilibrium results in a deflation of the lungs as a result of loss in pressurization. All right, and moving on, we're going to compare inspiration to expiration. So if you could do one more, Jose. Oh, okay.
I think there was an error with the slides.
Yeah, I mixed up the slides. Okay, let's do one more. Sorry, guys. Sorry. And then I'll go over this real quick. So pretty much during breathing, there's going to be changes in the volume, which lead to changes in pressure, and as a result, changes in airflow throughout the respiratory system, i.e. inspiration and expiration. So ventilation involves 3 different pressures: atmospheric, which is outside the body; alveolar, which is pressure inside the alveoli of the lungs; and intrapleural pressure, which is pressure within the pleural cavity. All right, so let's compare inspiration and expiration. So to start off, inspiration is the process of taking air into the lungs. It's an active process of ventilation because it's the result of muscle contraction. And during this process, the diaphragm contracts and the thoracic cavity increases in volume. So this decreases the intra-alveolar pressure so that air flows into the lungs. Whereas in expiration, thank you. Expiration is the process of letting air out of the lungs during the breathing cycle. So during this process, the diaphragm relaxes and the elastic recoil of the tissue decreases the thoracic volume and increases the pressure. So I feel like it's very easy to stress out and get confused, but a great part about this is you can just breathe in and imagine what's going on inside your body. All right, moving on. Pressure changes during quiet breathing. So you're gonna have to compare inspiration versus exhalation. So the important parts of the graph that was shown in the lecture is the intrapulmonary pressure. So this is the pressure inside the lung that decreases as lung volume increases during inhalation, and pressure increases during expiration. And for intrapleural pressure, the pleural cavity pressure becomes more negative as chest wall expands during inspiration. And then it returns to the initial value, chest wall recoils. And just another thing, the volume of breath during each breath, the pressure gradients move 0.5 liters of air into and out of the lungs. So next up, I have a clicker question for you all. So which of the following is not true regarding breathing? So I'm going to give about 10 more seconds. All right. So the majority said B. Let's see. The answer is actually C. So during inhalation, the thoracic cavity volume increases because the diaphragm is, it increases. So I just wanted to put this question out so you can see all the stuff that is correct. All right, and so these are just definitions you need to remember: lung compliance and lung elasticity. So I'm not gonna say it for you, you can look over on your own, but pretty much muscular breathing movements and the recoil of elastic tissues create changes in pressure that result in ventilation. And lung tissue contains elastic fibers, which are like rubber bands that pull back and snap back quickly. And they also make it more difficult to expand lung tissue. All right, and moving on to the law of Laplace. So alveoli range in size and therefore diameter. So pressure inside the alveoli is directly proportional to surface tension and inversely proportional to the radius of the alveoli. So pressure in smaller alveoli will be greater than those in larger alveoli. So this is just an important formula to remember. So this is a problem because of surface tension. So that's where pulmonary surfactants come into the equation. So just a reminder, there are type 1 cells, which are responsible for gas exchange. And right now we're talking about type 2 alveolar cells. And they are primarily for the maintenance and production of pulmonary surfactants. So pulmonary surfactants is a mixture of lipids and proteins, which is secreted by epithelial type 2 cells into the alveolar space. And its main function is just to reduce the surface tension at the interface in the lung to prevent the alveoli from collapsing. All right, and these are just a few more definitions to remember. And there's a formula: alveolar ventilation equals tidal volume minus dead space times respiration rate. And then another definition to remember is spirometry. It's just a tool to assess lung function and dysfunction. All right, so lung volumes and capacities. So this graph is pretty much just a lot of key terms that you should remember because they're very easy to just ask a question in a scenario type of way. So there's inspiratory capacity, that's air that can be breathed in after normal exhalation. Expiratory capacity, which is air that can still be breathed out after normal expiration. And tidal volume, air that moves into lung with quiet inspiration. And there are a few more key terms on the next slide as well. There's vital capacity, which is the amount of air involved in the deepest inhalation and exhalation. Residual volume, the air remaining in lungs after deepest exhalation. And total lung capacity, the volume of gas present in lungs after the deepest inspiration. All right, so I have another quicker question for you all. So if Dr. Azizi takes a deep breath in and deep breath out, the amount of air remaining in his okay, 5 more seconds. All right, let's see. The majority votes D. All right, that's correct for residual volume. So that is the air remaining in lungs after deepest exhalation. So I sort of mimicked the question that was on the practice exam. So it's very easy to put these in scenarios with the key terms. All right, moving on. Now, comparing pulmonary pathologies. So there's two types, obstructive and restrictive. So let's see what obstructive is. So obstructive pulmonary pathologies affect expiration or exhalation primarily. So that's the most important part. And I've included what is decreased and increased as well as examples. And moving on to restrictive. So restrictive pulmonary pathologies mainly affect inhalation. So these are tables that you can practice on your own that I highly encourage. All right, moving on. So I'm going to skip over this question because I believe you can all do it in your own time. But I feel like it's very important to be able, even though there might not be a picture on the exam, it's important to understand these differences in each photo and differentiate healthy from obstructive and restrictive. All right. I know I would do that fast, so are there any questions on this lecture before I move on to 16? All right, let's go into respiratory control. So I've included the basic rhythm, which includes the integrating center, the effector, and effect. And on the right includes the regulatory network. And this is just a more detailed pathway of what's going on. So I would say if you're having confusion over this, just get the basic first and then get into the nitty-gritty parts of the details on the right. So the pre-Botswinger Pacemakers, so these are autorhythmic cells located in the medulla that provide signals that control normal breathing. And we can actually track its location and visualize how these pacemaker cells work with electrodes. All right, and there's also two types of chemoreceptors that regulate ventilation. There's the peripheral and central. So first off, let's go over peripheral. So these chemoreceptors are located in the aortic and carotid bodies, and they detect changes directly in the plasma. So they can detect changes in partial pressure of oxygen, so partial pressure in CO2, as well as changes in pH. Whereas the central, it is located in the medulla. And this, I thought the most important was that it's indirect. It's not detected in the plasma. It goes through the cerebrospinal fluid. And it can only detect changes in partial pressure of CO2 and pH. PO2 not really, because that doesn't really change since a majority of it is binded to hemoglobin. All right, so I've just provided a sort of breakdown of the pathways for each of them. So for the peripheral, the stimulus is in the plasma. So there's going to be a depolarization that happens, and there are calcium channels involved with this. So at the end, there's going to be an exocytosis of neurotransmitters that trigger an actual potential and lead to inhalation or exhalation. And for central chemoreceptors, they're going to be a stimulus in the plasma that goes into the cerebrospinal fluid, which is indirect once again, and then it's going to lead to the effect, which is inhalation or exhalation. All right, so this is just a breakdown of the difference between changes in partial pressure of CO2 and partial pressure of oxygen. So the partial pressure of CO2 is the main driver of changes in ventilation because it's more accessible in the plasma, which is about 60%, whereas oxygen, there's only about 2% accessible in plasma. So there's going to be a dramatic decrease needed in order to detect changes in partial pressures of oxygen. All right, and I have another clicker question for you all. So the partial pressure of CO2 rather than the partial pressure of oxygen is the most reliable signal to inform our respiratory control centers because I'll give you about 10 more seconds. All right. So the majority of you said E, and the answer is E, correct. Great job. All right. So that is it for 16. Does anyone have any questions on that? All right, then I'm going to move on to 17. So this is exercise physio. So for this lecture, we're pretty much comparing acute versus chronic responses to exercise. So acute is during, and chronic is long-term exposure. So this involves three important parts: the respiratory system, the cardio system, as well as skeletal muscles, which provide our energy source for this. And in addition, there's the respirometry, which is just a measurement tool for aerobic activities only, since anaerobic activities don't rely on oxygen, and this tool measures oxygen. All right, so these are the three metabolic pathways of muscles that I've placed on a table. So there's creatine phosphate, glycolysis, and oxidative phosphorylation. So ATP is the high energy phosphate molecule that's going to provide energy during exercise because it enables muscle contraction. All right, so let's start off with creatine phosphate. So this energy supplies to the muscle. It's the first source of energy. It's an immediate source of ATP and phosphocreatine before any other form, which is glycolysis or oxidative phosphorylation. And it only works for, or it's the first frontliner for less than a minute, I would say. All right, and then for glycolysis, this is the next source for APT for a few minutes. So this process requires more steps that I don't believe you need to know. And it just pretty much involves the breakdown of glucose or stored glucose, which is glycogen, to produce ATP. And lastly, we have oxidative phosphorylation, and this is a long-term source for ATP that breaks down lipids, proteins, and carbohydrates for endurance activities. So this is the only long-term one and aerobic one. So this is sort of the loner out of the three. All right, I got another clicker question for you all. Okay, so a 2-minute sprint is most likely to use what as a metabolic substrate, while 5K is most likely to use what? All right, I'm just gonna give you 10 more seconds. Okay. All right, so the majority answer is A, but the answer is actually D. So for creatine phosphate, this only, we rely on this for a couple of seconds, a minute at most, whereas we rely on glycolysis for a couple of minutes. All right. Okay, and let's move on to the energetics of exercise. So there's a theoretical demand, which theoretically, when we start to exercise, there will be an instantaneous rise and an instantaneous drop when we rest again. But realistically, there's gonna be an oxygen deficit when we start exercising. And as we exercise, we're gonna go through a pay-as-you-go phase, which is when we're able to meet the demands by using our stored oxygen supply. And once we finish exercising, we don't rest. You know, we keep on breathing really hardly. Our body's still working to compensate for the deficit at the beginning with excess oxygen consumption. And these are the 3 different types of examples Dr. Azizi provided in a lecture. So for example, in light submaximal exercise, there's just gonna be a tiny deficit and tiny payback. And this is gonna be aerobic exercise. And heavy submaximal, it's gonna be more deficit and more payback, but it's still aerobic. Whereas supramaximal exercise, this is gonna surpass our maximum oxygen consumption that we do. So there's gonna be a huge deficit and huge payback. And this applies to anaerobic exercises. All right, so responses to exercise, there's gonna be changes in ventilation and cardiac output. So once the exercise begins, there's gonna be a slow incremental increase. And once you're done exercising, there's gonna be a large drop, but then it's still gonna drop a little bit more. So there is like these increases and drops when exercise begins and ends. So there must be a signal that indicates when to change our breathing pattern. And for cardiac output, there is blood is distributed pretty balanced throughout the body, the digestive system, our muscles, brain, you know, everywhere. But during exercise, there's going to be a large shift to the cardiac output and skeletal muscles. All right, and in submaximal exercise, blood gases and pH remain pretty steady. There's a graph provided in lecture, and they're pretty much constant the entire time until it reaches almost 100% of max O2 consumption. So arterial partial pressure of oxygen doesn't really change, or I would say doesn't change, whereas arterial partial pressure of CO2 and venous partial pressure of CO2, it only drops near the end, and pH, it drops around 75%. All right, so as you may know, blood pressure rises when we exercise. And here's the formula for mean arterial blood pressure. Just a reminder of what it is. So the systolic mean and diastolic arterial pressure is directly proportional to oxygen consumption, whereas cardiac output is inversely related to oxygen consumption. And this inverse relationship serves as compensation for stabilizing the blood pressure so it doesn't overstress the arterial system during exercise. Okay, now we're going to go over endurance training. So chronic changes in muscle. So I believe you can look over this. It's just pretty much memorization of what changes, but pretty much changes in blood flow patterns lead to more blood and oxygen to the working skeletal muscles. And the upregulation in capillaries and increase in blood flow to deliver more oxygen to tissues to meet the oxygen demands of exercise. All right, so more chronic changes that happen during endurance training. There is an overall increase in plasma blood cells post-training, but the percent of red blood cells is less than pre-training. So this results in less viscosity, which allows for faster blood flow because we want more blood to be bringing in oxygen to our muscles. And this increase in blood flow to muscles require an increase in cardiac output, which is a direct proportion to the increase in oxygen consumption. And the cardiac output is increased by both a rise in heart rate and a rise in stroke volume, which is done by stronger contraction by the left ventricle. So overall, the heart pumps stronger, and most of the changes are in the left ventricle. All right, and also there are more changes in respiration and VO2 max. So there's an increase in the maximal capacity of lungs to increase tidal volume and respiratory rate to enhance the rate of oxygen diffusion out of the lungs and into the bloodstream. So these are all changes associated with the muscular adaptations during exercise. And finally, VO2 max, due to endurance training, your VO2 max increases. So you're able to do the same exercise without having the same amount of O2 debt and excess post-exercise O2 consumption. So overall, these changes in endurance training, they just reduce the overall stress on the body during exercise. Yeah, so thank you. That is all for my lectures. So this is the QR code for the evaluation. Please fill it out. I know we are rushed, so that is something we need to fix. But your midterm number 2 is in 5 days, so good luck, everyone. If you have any questions, feel free to stay. Any clarifications, anything. We're here for y'all.
Thank you guys for coming. Happy Veterans Day.
Thank you. Good luck to you all. Feel free to stick around if you have questions. You're gonna do great. Don't worry.
Is that a 9 or G? Sorry.
GLE. Where it says forms?
After SUV,
Oh,
9.
That's a 9, yeah.
That's a 9. You can also just use your camera on your phone and scan the code.
Oh,
And
great. Thank you.
just
Thank you so much for the review session. Although you guys go very quickly, I'd rather that you go through all the material than kind of cutting it down and spending more time. So I appreciate trying to fit everything in. So
thank you very much, Sina. Appreciate that.
Yeah. Hope you guys benefited from it.
mm-hmm. These lectures were pretty bad with information.
Yeah, they were dang.
Mm-hmm.
Hey, thank you guys. You guys did a really good job. So,
Thank you. Best of luck on the midterm.
thank
Yeah.
you.
Thank you. Thank you.
Yeah. Currently.
We're honored to have you as our guest.
Okay.
Fellow biotech peer tutor.
Oh yeah. I'm also dying with the slides, so I know what you guys mean when you guys are talking about, oh, it's a lot of information. So, all right. Well, I'll talk to you guys later. Bye.
Bye.
Bye. Anybody sticking around for questions? Don't be shy. Thank you, Savannah. I'm sure everybody appreciates your wishes.
Hi.
No.
Are you still here, Sunway?
Sunway, you have a question for us?
Or did he fall asleep on
Ah, he said he's telling us that our slides are boring.
All right. Should I just remove him?
Yeah,
Oh, he didn't stop recording, by the way.
Oh.
How do you stop that? Stop video. No. Stop recording. Stop share.
I just removed him.
More.
Awesome.